Hi, everyone. Welcome. We'll give it just a moment to have others join. Representative, it's nice to have you on. I haven't seen you in just a few weeks.
I know. We've seen each other like almost every day, it seemed like.
Yeah, a few times a day almost.
Yes.
I know, it's been a little bit. Okay, got still some people joining. I do want to wait as people are still joining just to give it a few more seconds or so at least. And then we'll get started, depending on the amount of dialogue and such. I want to make sure we're using our time wisely over the next hour or so. Okay, we'll go ahead and get started. So thank you everyone for joining our behavioral health delivery working group today. And we do have a 1 hour meeting scheduled to go through some of the pieces of our survey results and some of the recommendations put forth by this group. As we just kick off our meeting, if you are one of the assigned working group members, would you please put your name into the chat and put which organization you are representing, just for the sake of our record keeping in our minutes. We'd appreciate that if you'd go ahead and write into the chat, put your name and your organization that you're working with. So the first order on our agenda is to look at the December 15th, 2023 meeting minutes. And if you haven't had a chance to review those, if you wouldn't mind just taking a moment to scan those minutes. And when someone is ready, if there are no objections, I'll go ahead and open the floor to take a motion to approve the minutes.
Jen, this is Russ. I will motion to approve the minutes.
Thank you, Russ.
I'll second.
Okay, thank you, Adam. All in favor? Just
Aye.
Aye.
okay. Are there any opposed? If not, thank you. The motion passes to approve the December 15th meeting minutes. Okay, we'll move to item 2, which is to go through the survey results and recommendations. I'm going to pass over. Sharon, if you wouldn't mind, do you have the survey results available to you that you could pull some of those up? Or Brent, do you have those that you'd be able to walk through? I'm going to pass off to Brent, and he's going to walk through the survey results with us here.
It would take me just a moment to get those. I did not have those up. I don't know if Brent is ready or not, but give me just a moment.
I'm just trying to share here. I couldn't get my microphone off either, so let me try and share. Okay. So the first thing I'll share is a summary that Sharon has put together of the feedback that we've received so far. Let me know if you can see this document. Let's see here. Let me see if I can make it bigger.
Thanks, Brent. We can see it.
That better? Okay. So just as we talked about this survey, I think, in our last 2 meetings. And here are the results so far. We've had only three of the actual work group members who have submitted survey responses, and we've received, I think, now 10 or 11 survey responses in total. The survey itself first looked at questions around the specific measurables or specific and measurable metrics that we were trying to get to in this. And I would say that the feedback in many cases for many of the questions identified the need for further discussion. Let me share another document that actually provides the survey results. That may be helpful here too. Let's see if I can find that one. That may be easier to talk through. Let's see. Okay. So just in terms of the questions, we asked 4 questions on the survey. We wanted feedback on the requirements to recommend specific and measurable metrics regarding the issues here you see in cell C. We asked for feedback on and recommendations as to how physical and behavioral health services may be integrated for the targeted adult Medicaid program, including ways the department may address the issues regarding filing of claims, authorization and reauthorization for treatment services, reimbursement rates, and other issues that have been identified by stakeholders. We asked for feedback on and recommendations on how to improve the delivery of behavioral health services to enrollees, including any necessary changes to statute or administrative rule. And then we asked a question about wraparound service coverage for enrollees who need specific non-clinical services to ensure a pathway to success. And these questions really reflected a lot of the discussion we've had with this group over the past year. And I think we've made some good progress on many of these issues, primarily around the prior authorization and our claims processing issues. I think we've done some great work there to try and resolve some of these issues. But it was clear to me as I reviewed the survey results, a lot of this discussion is going to need to continue beyond the life of this particular work group, because we really haven't reached consensus on many of these issues. And that's understandable, especially given the many different roles that the members of this work group are currently playing in the current behavioral health system. I think it's difficult to reach consensus or a common perspective on some of these issues. So we understand that a lot of this work is going to have to continue in other settings moving forward. Some of the things that I wanted to highlight as I look at the survey results, and from my perspective, our current system creates complexity that sometimes is very difficult for the managed care programs and for providers to navigate. Julie Ewing made the recommendation that we look at the data collection requirements for Medicaid members who are not being financed through OSUMH and potentially removing those particular reporting requirements from the PMHPs. And what I can say is that we're working very hard to reduce those reporting burdens. We've been meeting with our system for the past 6 months, and we've reduced by at least 43 required reporting elements for this coming year the amount of data that needs to be reported to us. And as a priority, we've established, if it's not absolutely required by the federal government, we're trying to back off and make sure that we're only requiring the reporting that's absolutely critical and necessary. to maintain the flow of these funds. So, Julie, I know there's more work to do in that area, but I think that's one that we have heard, and we're trying to we're trying to make some progress on. What I would say in that regard is that it's taken us 40 years to build this kind of complexity. It's going to take us a few years to get to a place that's where we want to be. But we've heard that message, and we're trying to work with you. So if any of you have comments or additional thoughts about that, I personally would love to talk to you, and that's still a priority goal of mine. So Emma?
Yeah, Brent, I think it would be helpful at some point, maybe just to go over that with the UMIC plans and the ACOs, because I know you've been talking to the rest of the system about that, but I don't think a lot of us are really privy to what you've already reduced. So I think that would just
yeah.
When we created the UMIC plans, one of the first things they said is, well, they better not be coming to the UMIC plan asking for that kind of data. But I know it's been a concern, and it's been a concern from at least, and Julie's not on today, so I'll just say it's been a concern because providers, from what I've heard from our conversations, have said, yeah, I'm not going to play in the Medicaid space if I have to do that. And that creates a real access to care issue. So
Sure. And I understand that. The challenge is they're not just our reporting requirements. They're reporting requirements that are required most often federally to maintain the flow of dollars that are going into these organizations. And so one of the challenges that I see is within the PMHPs, we have active, robust discussions about how to report this in the least burdensome way. And so I think that system understands these, but now that the system is a little more complicated and there are more players, I think my office has to communicate what data reporting requirements are absolutely required and what are optional. And then I'll use this as an example. We were discussing with HealthyU this week, some of the reporting requirements that Optum was requiring for paneling within a project that we were working on. And almost our entire system within the PMHPs reports that information as unknown, and that's perfectly acceptable. But I'm not sure that we've communicated that clearly to the entire system when it's okay to report unknown. And so we can do a better job on things like that. So we're working hard to do this. It's going to take us some time to work through this. Some of the other comments that I wanted to, there's many comments focused on the need for housing, for peer support, for case management strategies for this population. We agree, and my office is working hard to help with those issues. We're looking at our certification programs for case managers and peer support specialists. We're trying to make sure that those trainings are readily available. We're continually reviewing reimbursement rates. And I was happy to see some of this come in through this discussion too. And then what I'll say, it's hard to summarize much of the survey feedback because there in many areas there wasn't a lot of consensus around some of the questions that we were asking. But what I can say is that we're all reviewing these surveys. And we're trying to take this seriously, and we're trying to incorporate your feedback into our thinking so that the next round of contracts, the next round of area plans in our system reflect what's happening on the ground. So I appreciate all of your efforts to provide feedback. I know that many of you haven't. And what I can say is that I think from our office's perspective, from this division's perspective, we know that many of these discussions will continue, and we haven't quite nailed it yet, but we hope to. Russ?
Hey, thanks for summarizing the survey results and presenting them. I'm curious, in your comment that there's not consensus around the survey results, are you saying, so like two-part question, are you saying within the responses you received there's not consensus, or you're just hearing in the community there's not consensus? And what are those areas specifically?
So I think around the issues of integration, we received some feedback related to, at least some of the comments wanted to expand or to expand the responsibilities of the PMHPs. Others are advocating for expansion of the UMIC plans, and I think that's natural. So some of those issues around integration, I'm not sure that we have clarity in this group around what our next steps are with TAM, for example. And we will continue to have those discussions.
But Brent, if I could just add to your comments too, I think we have achieved consensus in some important ways through the work that was kicked off in like this working group, that then much of that work happened in the UMIC meetings, but then was brought back and reported to this group. And I think, Emma, you led sort of the reporting out and the design and development of some of that work. And I do think it was a result of these meetings that important milestones that were defined early on in the UMIC plan development were achieved. And so I do think we have to know the places of agreement around, first of all, provider credentialing, that there was a uniform process designed for provider credentialing that does now exist and is in place. And that did come about as a collective work between the parties, involved parties, and was directly related to one of our objectives here in achieving the goals around some of our authorization, reauthorization of treatment practices, some other standardized practices. And so I think that's one piece. The next is designing uniform prior authorization requirements and really getting on the same page with what is on a prior auth and what the criteria specifically are within that prior authorization. And there's been important work put forth in that area, which will be implemented.
And I totally agree. And I didn't mean to say that this group lacked consensus in some of those areas. I think we've accomplished a lot in regard to our priority issues. Trying to summarize the survey results in an honest way, many of you responded to those questions differently, and it's hard to summarize all of 11 responses in a way that I think is fair to everyone without just showing you everyone's responses, because many of you approached the questions very differently. So I think what Jen is saying is my presentation is not meant to say, this group didn't make some progress on some of these issues. I'm just trying to provide an appraisal of what's come into us on the surveys. So I hope that clarifies. Emma?
Yeah, and I appreciate that, Brent. And I think, as both you and Jen have said, we've got more discussions to take place. And I think even in terms of, we've been really focused on TAM, and that's good. And I don't think it has to be an all or nothing. I mean, I think even the survey kind of made everyone feel it's like you get to choose one or you get to choose two. There's nothing in between. And I think there is an opportunity to have, maybe different models in different places of the state, but we have not yet been able to just sit down in a, somewhat non-emotional way and just have that discussion about what models really work best where. I mean, it may not be a one size fits all. And I don't want to lose sight too of the rest of the population, because we tend to be really focused on town, but we're still, as a state, struggling with, you move like a few blocks north or, you happen to get pregnant, you're thrown into an entirely different service delivery system. And I want us not to lose sight of that as well, because I think there are some things we can do to make that better for our members across the board.
Yep. Oh, I agree. No, I completely agree. So, any other, I mean, what are we okay to share the survey results with everyone? I mean, that was one of my, I'm trying not to show names of people that responded. Are people comfortable seeing everyone's survey responses? Have we sent those out to you? I'm not sure what the plan is in terms of that. I guess that was my other question. Is it okay to share people's comments?
Yeah, I think at this point, Brent, this being the last meeting that we have on this, an intent to capture people's feedback, I think we could put it into an anonymous document and share some of the feedback that was given, if it's important to this group, to have that available. It's on the public record now, clearly, as we're presenting some of this data. So I think that's fair, but we can remove names and redact any sort of indicators that may disrupt that. But
okay, good. I think other questions about the survey or what we've received?
Hey, Brent, it's Russ. I've got just one other question. Just
Okay.
I thought I saw when you first presented that it sounded like, was it all ACOs that had responded, were representatives of ACOs?
Let's see. No, it's not all, but it was primarily.
Okay.
So I see one response from a representative from the PMHP, and a few from, I think, providers. So, but I would say the bulk of the responses came in from representatives of the ACOs.
Okay. Well, I think then I'm sort of assuming what you're saying is that there wasn't disagreement amongst ACOs on methodology in the survey.
I haven't not. It's hard to say across the board, across all four questions, and I haven't really evaluated it that way. What I would say is the survey responses we received in total, and many of you responded to the questions, perhaps from a different perspective, and that was clear.
Okay.
So.
Okay. Yeah. I mean, I could see, that depending on how someone's view of the questions, even within ACOs, we could have all responded with different information, but
Right.
But I would think that there wouldn't be. I think most of us supported proposed I think ACOs supported the proposed metrics the department came up with that were proposed to the group back in June of 23. We thought that was a good path forward. So I guess that's where, as I think about, well, what are the main differences?
Yeah.
Not what those main differences are. Is there a pathway to have the discussion about the differences so that we can have
So, and Russ, even on that particular question, as I look at the summary that we've put together, there were a number of responses that said we agree with the metrics that were chosen. There were also responses that said we think there needs to be more discussion about these metrics going forward. So there really wasn't unanimity which I wouldn't expect. It complicates this presentation in terms of trying to communicate to you what came into the survey responses. It would be easier just to perhaps share the summary and have you take a look at it. But Yeah, I would say that from the ACO perspective, there was, it'd be interesting to look at the survey responses by role and see if there was consistency across the members of the work group that way.
Okay, fair enough. Thanks for that clarification.
Yeah. All right, Jen.
Okay, if there are no other discussions regarding the survey and the feedback that was submitted to us, and I believe we had presented some of this last meeting with the opportunity and encouragement for others to submit responses as well. That is the information we have to share with you today. And I believe with that, that does wrap up what we would see as the collective recommendations made to the department in this area. With this, we have taken this feedback and certainly made some changes already. And according to this feedback, have implemented some recommended updates to our processes and to our operational workflows. Go ahead, Russ.
Hey, Jen, I know this, brings to a close the work group, I guess. I mean, one thing that would be, I think, useful is there have been, it's been a public meeting, of course, and there are action items from every meeting. It would be useful to see the action items from every meeting and which ones remain open and which ones have been closed. I know that one that remains open is an understanding and analysis of individuals who are moving between legacy, UMIC, and TAM and back and forth. And we know individuals are working or are moving that direction, constantly. I know within Select Health, we have identified recently that we have several hundred individuals in our plans at any given time who have housing needs. Mm-hmm. And they're best served at times in TAM, and they end up moving to TAM, but then for various reasons they lose eligibility, lose certain benefits, and move back into ACOs. And I think that data would help us actually understand the scope of the issue, and it's an open action item from a number of months ago.
Yeah. I think that's a good recommendation, Ross. We have not done the analysis. I think it's been a little bit tricky to do some of that work, as you know, with Unwinding and Prism and all the movement of members over the last year. With that in context, it does not mean we shouldn't do the work and evaluate where people are moving and how it can impact coverage and access to services. It is encouraging that we do have housing that will soon be available for new group of individuals that are justice involved, that goes beyond just TAM, but would expand that service to all justice involved individuals. So we are doing that work, which is just one step forward we can report on. But I do think it's important to look at, service delivery and where the gaps exist. And certainly the gaps are created by transition of one program to another, and assess those more closely and study that in the future. So we'll keep that as an open action item. Just because this particular setting has closed does not mean these items are not going to continue forward in their work. I think we've established a good frequency of having discussion on some of these items in other settings, and we'll continue to do that even outside the context of this work group. So thank you for that.
And Jen, I would suggest some of that data was pulled out of old system.
Yeah.
In fact, Brian, I think you pulled it in your previous roles, and maybe we could even just go back and look at that data. It was pre-pandemic, pre-Prism, pre-Unwinding, which would reflect a little bit of normalcy. And then, my suggestion would be maybe after the May release, where we clean up the rest of the enrollment issues. I think the one big change you just made in March will help stabilize some of that, that wonkiness that we have where people are coming and going, every other day. But I think it's something we could probably pull, at least in the summer, and see what's going on, after a lot of these enrollment and eligibility issues are kind of settled down.
Yeah, certainly. And that big release is happening yesterday, I think.
Well, yes.
So it goes into play this weekend, right?
Yes.
So,
And then the May
Yep.
release to help clean up.
yeah,
some of
should
that,
stabilize
right?
that.
So that'll be good.
Yeah, thank you. And Russ, also to your point, I mean, those notes have been captured, and we certainly have all the items that have been, we've moved over a very broad range of ideas and different proposals, topics that we've covered over the last 2 years, almost 2 years now, that we've been in discussion here. And I think there are some, while we've made progress in some of these key areas, there's really some valuable information we need to pull out of that and continue to evaluate and explore in future settings. So.
Yeah, thanks, Jen. And
Yep.
I wonder if, as we do some of that exploration going forward, I think it would be great to perhaps have a discussion also around the HIMSS database and how that's working today, and should ACOs have access to that? How could we have access, given we are part of that system?
Okay. Thanks, Russ.
Russ, I apologize. My audio cut out. But did you say the HIMSS database, like the homeless management, or did you? Okay, that's the database. Thank you.
The housing, yeah.
Yeah.
That GWS has.
And
Right.
the level of coordination as we build out our housing services as well, and how we share people who are receiving that benefit. I don't know if that could be improved as well, not just because of access into the database itself, but it's not just Medicaid that's providing those services. So I think you're probably trying to look beyond that, right? To see.
Well, I think as we work within the system with individuals that we have an enrollment for now who are in that system, we don't have visibility in, we're actually trying to get in touch with them, right? We know they have gaps in care. It's really difficult. And so that type of access would be extremely beneficial. And then I think, Jen, I thought, reading into your comment, this may be not what you meant, but maybe there are other structural pieces that are helpful in enrollment files. For example, if somebody's coming on and they're transitioning from TAM, something that helps us have visibility into that transition so that we can give continuity of care right away.
Yeah, I see the context of even building our justice infrastructure in the next year, 2 years. But really, definitely within this year, we're going to be working very closely on what these systems look like. I really believe what you're sharing, Russ, as sort of this desired improvements around care coordination and sort of identifying who needs what benefits and how we're going to hand those off to one another. I think we're going to learn a lot through our justice work that will translate to other work we're doing for Medicaid enrolled members as well. So we're looking forward to that as we thought about just even the pieces that are necessary for justice. I think it builds up a system that Medicaid members across our state are going to benefit from. So points noted, and we're looking forward to actually building the types of things you're talking about that can be globally beneficial for people moving out of various settings, right?
Yeah. Great. Well, thank you. We look forward to those discussions as well.
Yeah. Anything else from others?
Just Jen, we just during the legislation, this last legislative session, Senate Bill 27 passed, which will create a new behavioral health commission. And I see that as a forum for many of these discussions going forward. And And I would love to have some discussions with any of you offline about how best to structure that commission to continue making progress on some of these issues. And we have the ability to form groups there, but I think many of the issues we've been discussing in this group will remain a priority for the newly formed Behavioral Health Commission. This will be an 11-member commission. About half of the representatives will be appointed by the governor, and about half by legislative leadership. And so I think while this group is going away, I expect to see many of you back, starting as soon as this commission is formed, continuing many of these discussions. And I don't want to lose the progress we've made as we do that. So there may be members of this group that want to apply and become commission members. I think that would be wonderful. There may be ways for us to continue a lot of these discussions within this new group also. So I just wanted to put a plug in for the commission.
Thanks, Brent.
And I would hope, because let's face it, I mean, a lot of these commissions have limited time and, they are not necessarily folks that are working in the weeds. I would hope that we can continue to just have these discussions with the department where we work out the details in the weeds, and then those recommendations could go to the commission. But I can't imagine the commission's going to be able to get into the weeds that they would need to get into to address some of these issues. But we'll see.
Yeah, no, I agree. I really agree. Yeah.
Any other comments? Okay. Well, we want to thank you for the many contributions you've all provided throughout the last almost 2 years now that we've been meeting, and for your valuable input and the participation that you've had. So we will be continuing to follow up on these items as noted earlier, and continue working towards our goal of improved models of care for individuals in our state Medicaid programs. And this specifically was looking at TAM, but integrated models and how those can best serve our Medicaid members. So I want to thank you today, and we hope you have a nice weekend.
Thank you.
Thank you.
Bye.
Thanks, team.